Hello everybody. Today we're going to start with evaluation of the shoulder. When the patient has the arm in the neutral position, a lot of the pertinent anatomy that we need to evaluate by ultrasound is hidden by some bone structure, primarily the acromion and the coracoid process. In order to evaluate those structures, the soft tissue structures that lie underneath these bone structures, we're going to have to do some dynamic maneuvers of the arm in order to bring that anatomy out for easier viewing. The second part is by putting the arm in a certain position, putting the ultrasound transducer down, and moving the arm during ultrasound instination of that part, we are able to see how that soft tissue and bone structure are moving together. So it's important to understand why we do something and the reason behind it. Now, the second reason that we're going to talk about movement is there are people when they're having pain in a joint or having an injury that there is a limitation on what they can actually do. So during the examination, we have to be cognizant of the fact that full exposure of the anatomy that we wish to instinate may not be possible. But let's start with the arm position and looking at the shoulder. I'm going to start with the anterior and work our way from anterior, superior, superior lateral, and then posterior. Now, the first position that we always start in evaluating the shoulder is going to be the anterior view, and we're going to be looking at the long head of the biceps tendon. In order to view that, I ask the patient to bend their arm at 90 degrees, place their palm up, and comfortably lie the hand on top of the thigh. What that allows us to do is place the transducer in a position so that we can look at the long head of the biceps tendon in its short axis all the way down to the pectoralis major. We can then look at the long axis in the same position. And now if we want to move to the subscapularis, which is the next tendon in our structure, which is also an anterior anatomy, but primarily when the patient's in the neutral position, the vast majority of the subscapularis is hidden underneath the acromion. So to understand how to see that or to visualize that, we're going to ask the patient to externally rotate. Now, it's easier to show the patient what you want them to do than try to explain it to them. So I'll tell the patient, keep your arm tucked up against your side and just turn your palm out to the side. This maneuver allows for the subscapularis tendon that is normally hid underneath the coracoid to be drawn out and give us a window to look at the subscapularis both in its long axis and in the short axis. The next movement we're going to do is going to be looking for the AC joint. So I ask the patient to put their arm along their side and relax comfortably. In order to find the AC joint, I'm going to take my finger and follow it along the clavicle till I feel a little notch, which is the AC joint or the acromioclavicular joint, lying between the medial aspect of the acromion and the lateral aspect of the clavicle. Placing the transducer on top of that and taking an image, then asking the patient to bend their arm, put that hand across on their contralateral shoulder, and then we will take another picture of that area. It is common practice to look at both AC joints, so you might want to dress your patient such that you can do that. We let the patient relax their arm back down. What we're looking for in the AC joint is any type of underlying pathology or instability. So if we do see between the neutral and the cross-thoracic position any change in the position of the clavicle to the acromion, we may want to catch a dynamic clip of the patient putting their arm onto the contralateral shoulder and bringing it back down. Now, just to reiterate what we've done so far, we've looked at the long head of the biceps tendon in long and short axis. We've externally rotated the arm to look at the subscapularis. And we've also done the neutral and cross-thoracic maneuver to look at the AC joint. The last thing that we like to do on the anterior part of the shoulder is looking for coracohumeral impingement, which means that we're going to have to get a long axis of the subscapularis, and then we're going to have the patient put their arm in external rotation, placing the transducer over the coracoid and the humeral head, and we'll do a full internal rotation and external rotation 2 or 3 times to watch to see how well the subscapularis glides and the synchronicity of the subscapularis parts as they glide in and out of plane. Now, once we've accomplished all of our anterior superior anatomy, the next structure that we're going to look at is the all-important supraspinatus tendon. In the neutral position with the arm lying along the side like this, we see about 1 centimeter to 1.5 centimeters of the supraspinatus tendon uncovered from underneath the acromion. But we want to get better exposure, so we're going to ask the patient to do a couple of maneuvers to help bring the supraspinatus tendon from underneath the acromion, and so that we get a better view of a longer length of the supraspinatus tendon. Now, there's a couple positions that we're going to use for this. Number one is a position where we're going to ask the patient to put their hand behind their back with the dorsum part of their hand into the small of their back and try to raise the arm up. All important is where the elbow lies. We want to get the elbow as close into the body as possible. Sometimes due to the body habitus, this is impossible, but the idea is to get the elbow as close into the body as possible. This allows for the supraspinatus tendon to be pulled from underneath the acromion, and it stretches out for better viewing. The second position that we would like to have the patient get in, and many times this position is easier for the patient to get into, it's called the modified CRAS position, where we ask the patient to put their hand like it's in their back pocket. So having the patient this way, we have them put their palm into the area of their back pocket. And the all-important maneuver here is that we want the elbow pushed back towards the midline or towards the spine. That way we get better rotation and extension of the supraspinatus tendon from underneath the acromion. Now, the next position that we want to get in, and we'll start with the patient back in the neutral position, is I tell the patient, put your arm like it's in a sling, 90 degrees with the palm up, with the arm lying against the tummy. What this does, it allows us for exposure in the posterior aspect of the last structures that we're going to take a look at. Number one being the infraspinatus tendon. Second structure, the teres minor. Third structure will be the spinal glenoid notch and posterior superior glenoid labrum. Now, the glenoid labrum is not required for evaluation. Many sites do it as an additional look at the labrum, the posterior labrum. The last structures that we're going to look at are we place the transducer along the spine of the scapula in the long axis. By simply sliding the transducer anteriorly, the transducer will show the deep suprascapular notch on anterior to the spine of the scapula. Now, last structure that we do, or part of our normal examination, is we want to evaluate the muscle bellies of the infraspinatus and the supraspinatus. And the way that's accomplished is we'll take our hand and go approximately 3 finger widths medial to the lateral acromion. We'll place our transducer on top of the spine of the scapula and look down into the short axis of the muscle belly of the infraspinatus. And we'll also move the transducer anterior to the spine of the scapula and look at the short axis of the supraspinatus muscle at that point. Those would be the positions that we would have the arm in to look for evaluation of the tendon. Now, the last thing, depending on how you'd like to do your examination, we do a couple of dynamic maneuvers looking at the supraspinatus tendon as well. And this one is we drop the arm along the side, we rotate the thumb in, Placing the transducer on top of the lateral edge of the acromion, we ask the patient to raise their abduct their arm about 30 degrees and up and down. And we're watching for the slide of the supraspinatus tendon underneath the acromion. A second maneuver that we would do is we have the arm bent 90 degrees, palm up, and then I'm going to place the transducer on top of the lateral edge of the acromion once more, looking for the supraspinatus tendon in the humeral head, and we just have them raise their arm, elevate their arm up, watching for the slide of the supraspinatus tendon and the subacromial subdeltoid bursa underneath the acromion. Those are the primary dynamic maneuvers or basic dynamic maneuvers and positions of the body in evaluation of the shoulder.